السلام عليكم ورحمة الله وبركاته وأسعد الله مساءكم بكل خير. Good evening everyone and welcome to EpiCases 2024 session with International League Against Epilepsy Eastern Mediterranean Region webinar to address electrical status epilepticus during slow wave sleep, ESES. First, I would like to thank Professor Nermeen Keshk, who initiated this webinar. Also, would like to thank Professor Herenklos and President of International League Against Epilepsy, and Professor Ghaib Jandil, the President of EMR region, and the team of ILAE EMR for the support. Our epilepsy expert today is going to be Professor James Riviello. Everyone knows Professor Riviello, who is currently Director of Epilepsy Neurophysiology Neurocritical Care Section of Neurology and Developmental Neurocritical Neuroscience at Baylor College of Medicine. Professor Riviello entered Tufts University in 1970, graduated with double major in the classic and biology. Then he did pediatric internship, then pediatric neurology fellowship at St. Christopher Hospital for Children, and then critical neurology. Professor Riviello joined Boston Children's Hospital and worked in comprehensive epilepsy program with eminent epileptologists in Boston Children's Hospital. Professor Riviello developed expertise in epilepsy surgery, international recognition for treatment of epilepsy and epileptic encephalopathy, specifically Landau-Kleffner syndrome and ESES. In addition to his pediatric epilepsy role, he developed comprehensive teaching curriculum, neurocritical care program. He was one of the best mentor of me during this period. Professor Riviello left Boston Children's Hospital in 2007. He spent time in New York, then Columbia. He was the pioneer of epilepsy surgery program at Texas Children's Hospital, who is currently practice. He served as the director of epilepsy, clinical neurophysiology, chief of neurophysiology and development neurocritical care program. He expanded the service and started laser ablation program. Professor Riviello had numerous publications in epilepsy, clinical neurophysiology, and neurocritical care, and he got multiple awards and recognition. It's a pleasure and honor to have him as epilepsy expert for today's webinar. Welcome, Professor Riviello. In addition, we have 6 distinguished speakers from EMR region, and it is a pleasure to work with all of them. We have Professor Fatma Kammoun, who is professor and pediatric neurologist at Safakis, Tunisia. She is a member of Research Lab Neuropediatric at Safakis University, and she is a coordinator of Certificate of Complementary Studies, Neurological Disease and Childhood and Adult. Professor Fatma is a member of Scientific Committee of Professional Master Degree in Epilepsy, and she is executive member and founder of several Tunisian scientific associations. Professor Kammoun is also a member of several international scientific associations, and she is interested in epilepsy, EEG, neurophysiology, neurometabolic, and neurodevelopmental disorder. Welcome, Professor Kammoun. We have Professor Amal Sati, who is Professor of Neurology, Neurophysiology, Department of Muhammad, teaching Military Hospital, Muhammad University at Rabat. Professor Sati, area of expertise is epilepsy, adult and childhood EEG, dietary therapy, sleep disorder. Professor Sati has numerous publications and research projects related to epilepsy and clinical neurophysiology. Welcome, Professor Sati. Professor Nibal Wael. Dr. Nibal is Assistant Professor of Pediatric College of Medicine, University of Baghdad. Dr. Nibal is pediatric neurologist, Children's Welfare Teaching Hospital, Medical City Complex in Baghdad. She is the head of Epilepsy VNS Clinic, and she is a member of Executive Committee of Iraq League Against Epilepsy. She is a member of Scientific Committee and Pediatric Neurology Iraq Board Medical Specialization. Welcome, Dr. Nibal. Dr. Iman, Dr. Riham Al-Hariri and Dr. Iman Maher is a professor of clinical neurophysiology since 2020, Cairo University, Egypt, after obtaining bachelor degree of medicine and surgery from Cairo University, October 2001. She joined clinical neurophysiology unit as well as Cairo University epilepsy unit. Her clinical interests include epilepsy, especially EEG role in management of refractory seizure, as well as neuromodulation and general clinical neurophysiology. Welcome, Professor Riham Al-Hariri and Dr. Iman Maher.
Thank you, Dr. Aida. Thank you so much. I'm Dr. Iman. Thank you.
Welcome. Dr. Muna Ali. Dr. Muna Ali is a specialist pediatrician and pediatric neurologist at King Fahd Specialist Hospital, Dammam. Dr. Muna is well-known senior pediatric neurologist. She has multiple publications related to pediatric EEG and clinical neurophysiology. She has a special interest in Dravet syndrome. Welcome, Dr. Muna. The sixth speaker is Dr. Adana Hasbini. Dr. Adana Hasbini is a senior pediatric neurologist. She is professor of pediatric neurology and epilepsy in Beirut. Professor Hasbini has multiple publications. She has special interest in pediatric epilepsy and neurophysiology, and she has multiple research projects going on. So welcome all, and it is time to start. Professor Riham, welcome, and would you please start your first case?
Good evening. How are you? Good evening, Professor Vaiello. Thanks for allowing me to share this opportunity and share this case with you. Okay, can you see all of it now?
Yeah.
Okay, I will start. I am Riham Hamd Al-Hariri, neurology lecturer in Cairo University, and on behalf of my Cairo University epilepsy unit team, I will share this case with you. We will begin with history. She's a female child, age 4 years and 2 months, left-handed, with positive consanguinity, negative family history for epilepsy, normal prenatal history, delayed global milestone with no significant past history. At age of 2 years, the patient developed first seizure caused febrile generalized clonic seizure. Then after that, it recurred afebrile once or twice per day. No history of myoclonus and no loss of contact. She started liver strength 300 milligrams twice per day, and the frequency decreased to twice per month. No history of convulsive status or seizure clustering. At age of 3.5 years, the mother started to notice regression in her communication with the family members and behavioral deterioration, hyperactivity. The examination, general and neurological, were normal, apart from her IQ test was below 80, below average. So let's see here awake EEG. As we can see, it's slow background with diffuse slow spike waves, more frontal with 2 Hz, never exceed 2.5 Hz, 6 seconds, abundant, almost 60 to 70% of the record, with no abnormal movement or behavior. Her MRI was normal. Our hypothesis that 4-year-old female patient with global delayed milestone developed GTC with speech regression, and her EEG shows diffuse spike and short wave with 2 Hz slow background. So we said it's a developmental and epileptic encephalopathy. However, we think for other etiology, could be a focal lesional epilepsy. No, she has normal MRI. Could be an annexed gastrous syndrome. There is no tonic seizure, one type of seizure in EEG. No paroxysmal fast activity. No tonic in sleep more than 10 Hz. However, in annexed gastrous paroxysm in wake and sleep, boxes and one, not continuous and never exceed 2.5 Hz. Could be a Dosé syndrome. No myoclonus, neither atonic, whether clinical or EEG. So let's go to first question. Is a sleep record necessary for such case? It's a bold question. Can we choose? Okay. Well, very good. According to the mandatory criteria, sleep EEG is mandatory to capture other type of seizure occurring during sleep that may not be noticed, and other EEG pattern to confirm diagnosis. However, if the regression is enough and abnormal wake EEG in limited resource country, we can have enough only routine EEG. So in our sleep EEG, there is absent sleep architecture with rhythmic spikes slow wave, 2 to 3 Hz, 40 to 60 seconds, almost 90%, 95% of the record, with no paroxysmal fast activity, no abnormal movement or behavior. So the final hypothesis goes to a patient with cognitive and language regression with GTCs in post-wake and sleep EEG, abundant near continuous. So it's a developmental epileptic encephalopathy with a spike wave activation in sleep. Sorry. So according to the mandatory criteria, we are fulfilling all the mandatory criteria regarding seizure, EEG, age of onset, developmental onset with normal MRI, and we did the sleep EEG. However, there is no alert or exclusionary criteria. So the other question, can an app be enough in this case? The bold question. Can please all of you vote? Well, it's almost correct, but let's see the answer. Actually, the NAP can be enough. Yes. According to these papers that published in June 2023, it's a retrospective study on 10 children. They studied the daytime and overnight EEG records and calculating the spike wave index and spike wave density in both of them. Almost spike wave index show no significant difference between overnight study from daytime study. So we can use sometimes the daytime study. So how we calculate the spike wave index? We choose or we calculate the number of seconds that containing one or more spikes for the first 5 minutes. In our units, we calculate the early 5 minutes in the sleep, then multiplying it by 100 and dividing it by 300. As we can see here, we can calculate it 9 seconds containing spikes. So which epoch we can choose to calculate spike wave index? There is no consensus about duration, neither portion of non-REM sleep, whether early or late. However, there is a trend that the spike wave index is higher in early sleep cycles. So early 5 minutes of non-REM sleep is recommended. And how can we identify early sleep? We identify it with appearance of sleep spandel or first epoch of alpha attenuation, or in our case with lost sleep architecture, we can have the appearance of clinical sleep. So what is the value of calculating spike wave index? Help in diagnosis, whether it's atypical or typical case, according to the calculation, can help in prognosis, controlled or not, and can help in follow-up with disappearance of totally ES pattern, or more than 50% improvement or spike wave index, or less than 50% improvement spike wave index, or no response. And this was a retrospective study over 48 patients to confirm the importance of spike wave index in follow-up of patients and determine the cognition outcome. So back to our case, we add to levetiracetam sodium valproate 200 milligram twice per day, and we start synthetic ACTH 1 milligram intramuscular day after day for 2 weeks and tapered over 4 weeks after EEG follow-up. So this is the follow-up EEG, almost disappearance of epileptic discharge and generalized slowing, as we can see. This is after 2 weeks. However, after 3 weeks, after 3 months, sleep architecture returned again, and spike wave index, after recalculating it, it was 37%. So our follow-up, we were achieving primary outcome in cognition. How, as the mother said, the communication improved markedly, and she started to speak and ask about her daily needs. And we also achieved the secondary outcome regarding spike wave index in sleep EEG, with more than 50% improvement from 90%, from 95 to 37% decrease, and the seizure frequency, patients become free from last October till now. So she back to baseline as regarding cognition, speak, and language. Our question for the discussion: well, if the patient regrets again and she will be again, can we give her another trial of steroid, and for how long we can give her a trial of steroid? Thank you.
Yeah, thank you so much, Dr. Riham, for interesting case. And I think in this case, Professor Riviello is going to give comments. I will give the mic to Professor Riviello.
Okay.
Yes, and again, thank you to the organizers for letting me be part of this great seminar. And that was a very interesting case, in part because it is something that we see a lot clinically. Someone that has language regression in the setting of having had prior seizures. So I think to go through some of the questions, the first question is a sleep record necessary? And I think overall the conventional wisdom answer to that would be yes. For the most part, we're looking for sleep, and we're looking for a sleep activation. There are some centers that would look at the waking record and consider ESES to be not just a fixed spike wave index, but to be a greater than 50% increase in whatever the spike wave index was in the waking state. With the 85% as the typical, with the 50 to 85 as atypical, those are variable numbers depending. Well, those are numbers that were set by ILAE, but other people have used a spike wave index of 50% to diagnose ESES. They've used 25%. So therefore, how much you get sleep activation may be helpful. There are some people now that are doing some quantified EEG studies on a waking EEG to see if that could predict ESES, but so far we do like to have a sleep EEG. Now, question number 2, can a nap be enough? And the answer to that is yes. There's been a lot of work done that people have looked at the first even 100 seconds of sleep or the first 5 minutes of sleep and have said that the early sleep activation can predict an all-night a study for ESES. So if you have a patient in your lab who goes to sleep, you may not need to have a full 24-hour EEG. I believe that a lot of centers still, though, would bring a patient in and do a prolonged EEG to confirm ESES, but I think there's accumulating evidence that the first 100 seconds or 300 seconds of sleep may be adequate. You know, I've seen patients who came in that never had a sleep EEG, but had language regression, but they had EEG, say, spike wave index of 50% in the waking state. So it's almost like you know that if you were able to get a sleep EEG in those patients, that they would have a greater degree of sleep activation. And clearly what was pointed out is there is a variation in the spike wave index over the course of the night. We know that the spike wave index may be higher early on in sleep, and that the closer you get to the waking state in the morning, the subsequent spike wave indices may be less. You know, typically here we've been doing 3 cycles of sleep, the first 5 minutes, and then the next 2 subsequent minutes, and then using them to calculate the spike wave index. I do want to caution people about the 85% spike wave index. That was the spike wave index calculated in the original paper by Tassinari's group. And so they think that the 85% may really have been what we would call the tip of the iceberg, that 85% isn't absolutely necessary to call something ESES. And in fact, like the atypical may be 50 to 85. I think the key would be that if you have sleep activation, that's a biomarker that might indicate the potential for an epileptic encephalopathy. So I've heard people say, well, the patient doesn't have ESES because the spike wave index was only 50 or 60%. If I see regression in someone, almost no matter what their spike wave index is, if it's greater than 50% of the waking, I would consider that to be ESES. And I think as far as the treatment in this case, initially both the levetiracetam and the valproic acid are good spike suppressors. As you know, there are some anti-seizure medications that will suppress spikes. There are others that don't, but levetiracetam and valproate are what we typically use. And the thought is, if you treat early on, that you will get the patient under control. In fact, I have to bring up a work that Dr. Albarati did with us, where we had 12 consecutive patients with ESES, and we used valproate. And for the most part, the valproate didn't work if it was late into the treatment, but she showed that if you treat early on, that the valproic acid did work. So I think early on what you use is helpful, but especially if you use something that is a spike suppressor. The question of how long you treat with steroids, here it was 2 weeks and then tapered over 4 weeks. There really is not a consensus among providers about how long you have to treat for. What we do know is that if you have a shorter duration of treatment, that those patients may relapse. So it may take a longer period of treatment in order to get patients under control. The protocol that we had used at Children's for the difficult patients was 6 months, starting out with high dose the first month and then tapering it over 6 months, with the idea that if you kept the treatment on for longer, there might be less of a chance for regression to occur because you're treating for longer. And of course, the endpoint of the treatment will be controlling the spikes, but also possibly improving the cognition. I've seen patients who have had not the best response to a spike wave index, but clinically did better. So ideally, we would have no spikes, reduce the seizures, and improve the cognition, but it may be that cognition is the most important thing to aim for the steroids. And there is some evidence that patients that are treated with steroids do better than patients that are treated with the standard anti-seizure medications. But again, a very interesting case, and great that they brought the patient back to her baseline state with the steroid treatment.
Thank you.
Thank you so much, Professor Raviello. I have some questions from the audience. I will we'll manage it according to the time, and then we may go after the questions later on. But there is an interesting question. If there is place for genetic testing in such case?
You know, personally, I would do genetic testing in everybody with a hard to control epilepsy. You may not find something that alters treatment, absolutely, but you may find etiology. And I think etiology is always very important in pediatric epilepsy. And of course, we do have some genetic disorders in which there may be a specific treatment. And for ESES, we have the GRIN2 abnormalities that may be associated with electrical status epilepticus of sleep and may respond to even other medications like memantine, which is an anti-excitatory agent. So I think there is a role for that. The question is, how easy is it to obtain?
Okay, thank you so much. I think there are, it provoked a lot of questions. So I would ask the audience, would you please, when you put the question, put the case number 1 or 2, and we definitely are going back to your questions at the end of the presentation. So I think we can move to second case, Professor Fatma Kammoun.
Hello.
Again, we have another interesting case.
Thank you. Thank you very much, Professor Raida. And thank you for all the organizers to give me the opportunity to present and discuss with you this clinical presentation about this boy. It's a 13-year-old boy with normal motor and cognitive development. He has some academic difficulties that are not explored. And he started to have a focal epileptic seizure, a motor tonic of the face. He has the first seizure at the age of 8.5, and the second seizure at the age the first awakening, as you show here. It is a repetitive biphasic spikes followed by slow waves on the left temporoparietal region elevation. And here also some spikes in the right temporal region. He had also a normal brain MRI. Excuse me. Her doctor decided to treat the child with valproate, and 2 months later, when the child back to school, parents and the teacher noted slowness in activity, and particularly when he responded to question with hypotonia. Also, he had the recurrence of another motor epileptic seizure. So the first question, what is your decision at this moment? You will decrease the valproate dose, switch to another anti-seizure medication, to prescribe neurocognitive assessment, a sleep EEG, or to wait and see. Yeah, the majority noted a sleep EEG, and there is also a proposal to switch to another anti-seizure medication. I think at this moment we can prescribe a neurocognitive assessment and a sleep EEG. But the doctor of this child decided at this moment to have a second EEG but he had also an awake EEG and sleep EEG are not obtained at this moment. Here I show you again the second awake EEG. There is some sporadic spikes in the left temporoparietal region with diffusion to the adjacent region. And we show is also here some rare spikes in the right temporal region. So her doctor decided to switch to carbamazepine at this moment and to stop valproate, but with incomplete improvement of the slowness of the child. And after this therapeutic change, the patient are referred to our child neurology department. He had normal clinical evaluation, but we noted the slowness in activities, and particularly when he responded to questions. So at this moment, we decide to evaluate the language and to have a neurocognitive assessment. So our evaluation, we noted a lack of words with increased latency to respond. There is an impaired automatic language and impaired sentences repetition. All these modifications are in favor of condition aphasia. He had also a neuropsychological evaluation. He had a global intellectual quotient of 77, and we noted also an impaired praxis function. He had, of course, some attentional and memory disorder, but they are a consequence of the language disorder. So at this moment, we decide again to have an EEG, an awake EEG, and particularly a sleep EEG. So we move to the second question. What type of sleep EEG you will prescribe to this child? A first non-sleep REM cycle, nap sleep EEG, 24 hours EEG, all night sleep EEG, or only the first 30 minutes of non-REM sleep, or the first and last sleep cycles. Yeah, you are mitigated between all this response. I think we can have a nap sleep EEG. It is sufficient to show if there is a sleep activation for this child. So the child have a nap EEG. Here I show you the awake EEG. We found the same spikes in left temporoparietal region. There is an activation during hyperventilation, and you have the spike and the slow waves with diffusion to all derivation. And during sleep, there is an activation of this spike and wave with a high amplitude, with a maximal amplitude in temporal and parietal left region. There is also an alteration of sleep spindles that are rare and short. So this first question, what is the sleep EEG grading for this child? The majority choose grade 2. No, it is a grade 4. Why? The grade 4 is defined by a distracted background. We can have also intermittent slow wave focus that are absent at this moment, a high amplitude spike and waves, and the diffusion of both hemispheres, and eventually a generalized burst of spike and wave discharges. So grade 4 and 3 are characterized by the synchronous and generalized spike and wave discharge, and in favor of grade 4 and grade 3, to distinguish from grade 0, 1, and 2, we must have a distracted background and particularly sleep spindles during sleep. So we made the diagnosis of Landau-Kleffner syndrome according to the diagnosis criteria of the International League Against Epilepsy. So we have a regression of language, and you have a slow spike and wave abnormality during non-REM sleep. So the last question, what is your therapeutic decision at this moment? You add a benzodiazepine or stop only carbamazepine to switch to levetiracetam, or stop carbamazepine and add benzodiazepine, or start corticosteroids. Yeah, the majority, 38%, we decide to start corticosteroid. And only 5% choose to stop carbamazepine only. We have a different possibility, but the most recommended for this child is to stop carbamazepine and to add a benzodiazepine. We can start also corticosteroid or to switch to levetiracetam. So for this child, the problem that the family refused any therapeutic change since he had no seizure recurrence after carbamazepine. So we add only clobazam at the dose of 0.5 with speech therapy. But the patient had an incomplete improvement. And the sleep EEG, there is no improvement, and we have an more distracted awake EEG. We have an abundant discharges of high amplitude spike and wave with generalized discharges during the awake EEG with a focal slow waves in the temporofrontal region. And during sleep, we have a spike and wave with high amplitude and diffusion to all the two hemispheres. They are generalized, and you have a very rare sleep spindles. And here I show you also the focal slow activity in the left temporal, parietal, and frontal region. Here, the spike and wave have a maximum amplitude in T5 electrode. And also, we recorded a focal motor tonic during sleep at this moment. So the parent accepted to stop carbamazepine to switch to levetiracetam in association with clobazam. And 4 months later, the child have normal awake and sleep EEG. And here I show you her sleep EEG 4 months after stopping carbamazepine. So the child is still on levetiracetam. We stopped the clobazam after having a normal sleep EEG. There is a regression of aphasia, but he still have academic difficulties in language learning in Arabic, French, and English, but he had normal awake and sleep EEG at this moment. So the take-home message from this presentation that to think that self-limited focal epilepsy can evolve to ESES. So sleep EEG must be considered in our routine evaluation. ESES can be induced by anti-seizure medication, particularly with carbamazepine and oxcarbamazepine. And in the management, we must stop with carbamazepine and to use clobazam at high doses to improve the EEG and clinical, but steroid can be more effective to improve cognition. And thank you for your attention. And Professor Riviello, the floor is yours to have some comments. Thank you.
Yeah, thank you so much, Professor Kamoun. Is really challenging case, and I'm sure Dr. Riviello is going to discuss about certain offending factors related to ESES.
Yes, again, thank you for that interesting case. And it brings up a very, very interesting point about the aggravation of any kind of epilepsy by anti-seizure medications, but particularly the carbamazepine and the oxcarbamazepine in the setting of ESES. Now, we all know that, or it's well known that generalized epilepsies, and by generalized, we might have spike and wave discharges in there. We know that generalized epilepsies get worse or can be worsened by carbamazepine or oxcarbamazepine. However, I think focal spike and wave can also be aggravated by oxcarb and carbamazepine. And so I think it's very important to keep this in mind, especially if we're treating the benign Rolandics, or now what we would call the select patients with oxcarbamazepine. We had seen, I think, at Children's about 5 patients who started out with what was otherwise thought to be benign Rolandic epilepsy. And I'm sorry, I say benign Rolandic epilepsy. I should now say selects, but benign Rolandic epilepsy selects, who after treatment with carbamazepine evolved into the Landau-Kleffner syndrome. So it is possible that the carbamazepine could have aggravated the epilepsy. If you look at a list of anti-seizure medications that have aggravated epilepsy, the list is actually just about every anti-seizure medication used. So even though there are some, particularly more the medications that are good for focal epilepsies that may aggravate epilepsy, you have to keep in mind that almost every med that we use might aggravate an epilepsy. For the question about the selects, it recently has been said that about 37% of patients with selects may evolve into an ESES-like picture, either typical or atypical. So we have to keep that in mind when we see the selects patient. So I agree in that case that I would have, as you did, stopped the carbamazepine, and then treated the patient subsequently with a more anti-seizure or spike suppressor medication. There may not be a right answer to what you choose next. And what do I mean by that? There's many things that can be done, but I think along the lines of the ESES patient, and especially an ES patient that starts on levetiracetam or is on levetiracetam or valproate, I probably would go next to a benzodiazepine and do clobazam. We have experience now with high-dose clobazam the same way we had experience with high-dose diazepam. The paper out of Boston Children's used clobazam doses up till 30 milligrams. And these can be started as an outpatient and worked up slowly. Depending on the weight, you could start at 5 milligrams a night or 10 milligrams a night, give it at night, and then increase up to 30. So we typically might do that next. However, there is data that the cognitive outcomes for ESES may be better with steroid therapy as opposed to the anti-seizure medication or the benzodiazepine therapy. And I think people may be aware of the rescue ESES trial that was being carried out in Europe, where they were testing clobazam versus steroids for the treatment of ESES. And that study has been published, although some of the data yet didn't show a major difference in the two. And I don't think there were enough patients enrolled to make a better chain, or to make a better assumption of that. So in this particular case, of course, the family didn't want to keep the patient on the long-term anticonvulsants. And so once the clobazam helped the patient get under control, they then used the levetiracetam only, and the patient responded. So I think this is, again, a nice example of the relationship between the various anti-seizure medications, the ESES, and the possibility of aggravation.
Yeah, thank you so much. Really challenging case. Actually, all of the 6 cases, everyone has a certain point of education, and it's really challenging. I still promise the audience to go back and answer their questions at the end of the 6 cases. Please write the case number on your questions. Our next speaker is Dr. Mona Ali. Dr. Mona Ali is a neurologist, pediatric neurologist at King Fahd Specialist Hospital, Dammam, and she's having also another challenging case. So, Dr. Mona, تفضلي. You can share your presentation, Dr. Mona.
I'll share it. The bottom shared screen is not working with me.
Okay, I'm going to share it for you, and then you can just tell me when to go on to the next slide.
Because there is some changes in this, I would like to use my own PowerPoint if possible, but the share button is not working with me. 1 minute. Now, okay. Is it clear?
Yes.
Okay. Assalamu alaikum rahmatullah. Good evening, everyone. I would like to thank the organizing committee and Dr. Raida for this opportunity, and also I would like to thank Prof. Fiallo for his presence at this meeting, and we really appreciate his presence. Our patient is an 8-year-old right-handed girl. She was first seen in our hospital at the age of 4 years, and at that time she was referred to our department from neurosurgery for evaluation, a case of arachnoid cyst for further management, and she had first onset seizure. Yeah, her semiology at that time was informed in rise tonic-clonic seizure. It occurred mainly during sleep. It was prolonged, and she had a total of 2 seizures. Her last seizure was at the age of 4 years. She didn't have any more seizure, and she was well controlled on Keppra, taking 45 milligrams per kg per day. Her development was completely appropriate for age, and she is doing well. She didn't have any cognitive or memory concerns. Past medical history was remarkable for a diagnosis of factor II deficiency. She had been diagnosed in the neonatal period when she presented with persistent umbilical bleeding. She also had left eye squint and some nystagmoid eye movement, which were observed at the age of 6 months, and she regularly followed with ophthalmology. There is a positive family history of epilepsy in one parent cousin. Her examination was completely unfocal exam. She didn't have any dysmorphic features, only this intermittent nystagmoid eye movement. This is her first EEG when she arrived to us. This is a background consisting of 7 hairs posterior dominant rhythm, which is well regulated and well sustained. Interictal discharges were seen bilaterally, mainly in the frontal, temporal parietal, and with shifting predominance. When she goes to sleep, we notice this continuous spike, slow wave complexes, high voltage, generalized, and it occupied almost 80% of the non-REM sleep. Then this is the history. Our question, if you have this child who presented to you with 2 GTCs controlled completely on Keppra, she had a normal development and no any concern regarding cognition, memory. Our sleep EEG showed the ES pattern we just showed. Would you go to treat this patient? The question to audience. Okay, good. There is good response from the audience, almost 90%. Okay. Actually, there is no right or wrong regarding this case, especially when she presented to us, she had normal cognition, normal development with no any concern. So, according to the criteria for ILAE classification regarding developmental and epileptic encephalopathy, which is WAS, the criteria consist of two phases. The first one is having this continuous spike slow wave during non-REM sleep, and the other two or more elements of regression, either in cognition, behavior, posture, etc. Our patient didn't have the other part, so you can argue that you can treat or not. However, we choose to treat her, and we started her on valproic acid. Our next question: if you decide to treat her, what medication you would like to choose? Any answer from the audience? Okay, almost like similar response. Almost similar. So we decided to treat her, and we chose valproic acid because it is known effect on the EEG, and it's known to decrease the spike slow wave. And we started her on valproic acid. Then we thorough evaluated her. We did metabolic screen, which was negative, epilepsy panel, and West all came negative. We did MRI. This is her MRI. This is T2 flare. It showed this arachnoids which is persistent from before. It sits on the left part of the quadrigeminal system. However, it did not exert any compression or any mass effect on the surrounding structure, and it was stable throughout the follow-up imaging. The SWAN sequences had shown this microplate in the left thalamus. It's also seen in the corpus callosum in the posterior aspect, and this right frontal subcortical and cortical hemorrhage in the right frontal. This is a report: stable left quadrigeminal plate sustained arachnoid cyst, and all blood products along the left thalamus, posterior aspects of the linear of the corpus callosum, as well as right frontal cortical and subcortical areas consistent with all insults. She underwent also MRI orbit because of her nystagmus almond, which just saw optic nerve atrophic shifts bilaterally. We followed her. She didn't have before baseline neuropsychological evaluation, and while follow-up we did for her. And this test showed she had mild intellectual disability. This is the course and follow-up. She came to us on December 20. At that time, she was on Kebra, and her slow wave index in sleep, it was 80%. We elected to start her on valproic acid, despite she didn't at that time any reported of any cognitive concern. And follow-up, we admitted her to our EMU, and at that time it showed like a spike wave index almost 80%. We gave her rectal Valium 1 milligram per kg, and next morning we observed that the percentage of a slow wave index came down to 50 to 60%. She continued in Kebra and valproic acid. And then we started her on escitalopram because she's still having up to 50% slow spike wave index in sleep. And then, on August 21, we admitted her to our EMU. And at that time, we found it had to have up to 80% spike slow wave index in sleep. At that time, we started her on lacosamide as a supportive also with good efficacy according to literature. This is how follow-up EEGs for 2 years from 2020 to 2021. If you can see, this is continuous spike slow wave activation in sleep. So despite all this treatment, we really observed minimal response regarding the ES pattern, and she started to show some cognitive decline on the second neuropsychic evaluation, which showed like 83, which indicate moderately low, and her performance mainly was low in the communication domains and the tasks that required academic ability, including reading and writing. And at this point, we decided to escalate her management. We admitted her to EMU. with the spike slow wave index up to 60%. We start her on prednisolone course 2 milligram per kg and plan to taper over 6 months. However, she got severe side effects, including hypertension and weight gain, and she required temporary antihypertension medications. She continued to have this 50 to 60% spike slow wave complex. We started her on Tyramate, and we went lacosamide. And next, we also gave her IVIG 2 gram per kg, and we started her on modified actin. However, between she was also on steroid tapering dose. Between April and July, we observed some improvement with this low wave index that reduced up to 20 to 30%, while on prednisolone, Tyramate, and MAT, it kind of combined action. Probably most effective agent was steroid, probably, and modified Atkins. And then, unfortunately, again, during follow-up, it traced again after 3 months to 50-60% spike slow wave in sleep. And this is her EEG. In subsequent next year, it was almost again almost like 60 to 80% of spike slow wave activation in non-REM sleep. And in the last EEG done just in January, we couldn't obtain a sleep EEG. It was a wake record. It was the same interictal discharges in bilateral frontal and bacterial temporal parietal region. However, we captured this 5 to 8 seconds of 3 spike wave, 3 Hz spike slow wave complexes mimic absence, but however, this was never associated with any clinical, neither sparing nor bothering, nothing. It was like just incidentally found. We did not detect it before. At this point, our question to the audience: what is expected outcome in this case? No improvement or normalization of the EEG and slow wave index. The younger the child, the better, or depend on etiology and duration of ESES. Pause from audience. Yeah, the extract, this is the right answer. Almost the prognosis usually depend on the etiology, onset, and duration. And the younger the child, always this was not associated with good prognosis at all. So our case diagnosis was she had this epileptic encephalopathy with SWAS activation, most likely secondary to thalamic hemorrhage that she had sustained in early infancy, probably secondary to high bleeding tendency. I searched in the literature, I found many reported cases and some studies. This study was old a little. It was reported in 2013 about neonatal thalamic hemorrhage that is strongly associated with electrical status epilepticus in slow wave sleep. And mainly this was studied in patients with straight sinus thrombosis without evidence of more widespread cerebral hemorrhage, and they found that those are at high risk of developing ESES spectrum, and in their cohort, almost up to 30% have developed ESES spectrum. Another more older study in 2005, early thalamic injury was associated with epilepsy and continuous spike slow wave during slow sleep, and this is a more larger cohort of 32 patients. Almost they found 29 of these patients having ESES, and almost like 40% they develop CSWS, which is the new term is epileptic encephalopathy with SWAS activation with sleep. Regarding the management, this is a recent released article. It's a randomized controlled trial. Corticosteroid versus clobazam for treatment of children with epileptic encephalopathy with spike wave activation in sleep, the rescue ESES, multicenter randomized controlled trial. It's RCT at 8 tertiary referral centers in rare epilepsy center in 7 European countries, children eligible from 2 to 12. and were diagnosed with epileptic encephalopathy with this was within 6 months. They never received any corticosteroid or clobazam previous before they enrolled in the study, and the outcome mainly focused on cognitive functioning after 6 months of treatment. Their interpretation, because this trial was terminated prematurely, the target sample was never met, so they reported that their finding must be interpreted with caution. However, their data released showed improvement in IQ outcome with corticosteroid compared with clobazam treatment, but there was no difference in cognitive sum score. Their finding strengthened those from previous control trial that supports the early use of corticosteroid in children with epileptic encephalopathy with SWASH. And I would like to share with you this multi-center study from Saudi Arabia. It included 11 centers. Our center was one of these participating. It's about developmental epileptic encephalopathy with SWASH in Saudi Arabia, clinical, etiological, genetic, and outcome in multi-center study. It's almost like 10 years duration study of from 2010 to 2020 at 11 center. The etiology as shown in this table, it showed that there is a higher prevalence of genetic metabolic causes, almost constitute like 35% of the cohort. And the study also found superior efficacy of combination therapy with steroid and benzodiazepine in developmental epileptic encephalopathy with SWASH. However, more study and assessed protocols, treatment protocols are still. I would like also to take the opinion from the expert, from Professor Rafael, regarding the use of memantine. We know memantine is precision medicine for epilepsy and disorder related to green 2 gene mutation. However, some report shows that it has a promising role in epileptic encephalopathy. This is an article about randomized placebo-controlled crossover trial with memantine in children with epileptic encephalopathy rather than green 2, and they show their promising result. And their cohort of around 27 patients aged from 6 to 18 years, and they show that there is a response rate up to 35% and EEG improvement up to 30% in memantine group. Also, the seizure control reaching up to 30%, while 7% in those on placebo. And at the end of this case presentation, I would like to ask the expert panel, Dr. Rafael, regarding our patient. What is the further management option regarding how we've already tried a lot of the medication? Shall we go for a trial of memantine or repeat a steroid course despite she had previously severe side effects, or we choose a surgical option including multiple subpial transection or DBS? And also would like to ask about the duration of treatment and how frequent we repeat EEG in follow-up of such patients. And thank you again.
Yeah, thank you so much, Dr. Amina. It's really a challenging case and very difficult case that used various medication and what to do next. So please, Dr. Ofillo, for your comments.
Yes, again, thank you, Dr. Mona, for that case. And this is a very, 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 I could underline very many times, interesting case, and say that we probably could talk for hours and hours and hours about just this case. So I'll try to be short and answer your questions. But I think the trial of memantine may be something to use first. I think memantine is quite safe. Again, memantine is an anti-excitotoxic agent. And when we have the ongoing ESES, I mean, we think that one of the mechanisms of brain injury is that you have excitotoxicity. So I might try memantine first on that patient. And the reason is because of how long the patient's been treated and for how many different things you've tried already to get them under control. So it may be that it's hard to control the spikes, but the memantine may be protective against some of the brain injury. Some other interesting points about this case, I would start out by saying that, initially you had the patient present with a seizure before they had regression, and that, patients with ESES, if you look at the stages of ESES, initially there may not be regression. So if you see a patient with ESES on the EEG, not all of them will have had regression at the onset. They may have presented with seizures. And like one of your questions before was, would you treat that patient? And I totally agree, with the fact that you treated that patient. In fact, you're partly treating because you don't want to, you may prevent regression if you treat early enough. Now, again, in this specific case, the arachnoid cyst in the quadrigeminal plate cistern and some of the MRI evidence of hemorrhage in the thalamus, if you put that together with what you presented from from Francesco Gazzetta's study and what you showed from Flor Jansen's work, that if you see a patient starts with seizures, has a very sleep activated EEG, and that they have had early thalamic injury, well, that patient is going to be a setup for ESES, and early treatment might help. In this case, you treated very early, but they still went on and regressed. And we've talked about this before. What would you use first? I typically would use, perhaps just as like something along the lines of levetiracetam or valproic acid first. I might use clobazam first, because again, the clobazam is what's been tested in the Rescue ESES trial. I don't usually use clobazam first myself in the US because it's hard for us to get clobazam as a first-line medication. We have to prove to insurance companies that something else failed before we move on to clobazam. Bringing up the idea or the location of the quadrigeminal plate cistern arachnoid cyst in and of itself, well, that's probably the cyst itself is probably incidental to the ESES. It's probably there because of the hemorrhage breaking up the arachnoid coverage and producing the cyst. I think it's more the location in the quadrigeminal plate thalamic region that is what's generating the ESES and not the cyst itself. An arachnoid cyst in the middle cranial fossa, particularly around the temporal lobe, may actually be more of an epileptogenic lesion. You brought up the point of the neuropsychological test. Neuropsychological testing, I think, is quite important in the management of ESES, particularly if you have a patient who early on does not have any cognitive dysfunction. Follow-up or repeat neuropsych testing can be very helpful, that if you see the patient losing ground, then that might be that's a reason for doing more aggressive kind of treatment. You use the rectal diazepam, and we had been proponents of rectal diazepam early on, and it is something, if you have a patient in the hospital, rectal diazepam could work very quickly to reduce the ESES, because you can give it, you can give a large loading dose and you might see an immediate improvement in the ESES. And even if you don't see an immediate improvement the first night, we sometimes might give a second or third dose each night to see if we can reduce the spike wave index. You use acetazolamide, very interesting, right? The acetazolamide is a carbonic anhydrase inhibitor. It has subsequently been reported for use in ESES. I had used it in some ESES patients years ago, refractory to other treatments, and it does work. The interesting thing about acetazolamide is with the carbonic anhydrase inhibition, that is similar to the anti-seizure medication Solthiam, which is available in in Europe and I think parts of the Middle East. That can be good for ESES. And of course, what you used later was the topiramate, which is also a carbonic anhydrase inhibitor. But using the steroids, you got the side effects, the weight gain and the hypertension. There now has, as you know, has been some work where people have used pulse steroids, monthly treatment rather than daily, to avoid some of the prolonged side effects. There are people that have been using, pulses of dexamethasone for 3 to 4 months monthly and seeing if that helps. You used IVIG. And of course, Professor Hasbini knows from her mentor in Lebanon, Dr. Makati, that Dr. Makati is a proponent and has shown that IVIG alone can be helpful for the treatment of ESES. So you use that, you use the ketogenic diet. So of course, you did just about all the different things that you can do, for ESES. I do have one comment about the thalamic hemorrhage and what came out as the relationship with the thalamus and ESES. There were papers in the 90s that looked at the relationship of a shunt to ESES, but what they didn't put together was why the shunt was placed. And if a shunt was placed for an early thalamic hemorrhage with hydrocephalus, well, then that was probably in part what was generating the ESES and not so much the shunt in itself. And of course, we ended with your question about the use of the memantine, and the genetics can be helpful for that, looking for the GRIN2s, but I think the memantine can be helpful in general. So then your question about the trial of repeat steroids. Since the steroids worked before, I realized that the family didn't want to go back to them because of the adverse effects, but maybe this would be a case for the pulse steroids rather than the daily steroids. Your question about the MST. The MST might be better if you had a primary focus for a Landau-Kleffner ESES patient. What do I mean by that? Well, in this case, the ESES may be driven by the thalamic injury, the deep injury. And we know from hypothalamic hamartomas, right, that hypothalamic hamartomas can have projected foci to other cortical areas. And if you resect the cortical area that you see the spikes in, well, that's not going to help underneath the seizure. So I probably would not do an MST in this patient. Your question about the DBS is quite fascinating, because with a if thalamic injury is the result of this, is the cause of this patient, then thalamic DBS might be helpful as a neuromodulation technique. So I think that that's a very, very interesting point. And finally, I don't want to talk too long at this point, but for how often I would follow up with the EEGs once I've done a treatment, I generally would do an EEG every 3 months to assess your response.
Okay, thank you so much. This is really kind of interesting case, very challenging. Patient continued to regress, unfortunately, about whatever we are doing. And it is an example how much ESES can be challenging. Thank you very much, Dr. Amuna and Professor Riviello, for all of these comments. You're very useful. We have 3 more also very interesting and very challenging cases. I would really appreciate for speakers to stick to the time so we can answer the rest of the questions. Our next speaker is Professor Amal Sati. Professor Amal, the mic is yours.
Thank you, Professor Raida. I would like first to thank you, Professor Raida, and Professor Riviello for the opportunity to discuss our cases. I would like also to thank Jessica and Gus for their help organizing this webinar. So I'm going to share with you the story of Abdel Moz. Can you see the slide?
Yes, it's clear.
Abdunnoor is born from a well-monitored pregnancy with a normal delivery without any complications. There was no consanguinity between the parents, no similar cases in the family. However, the mother reported that he had delayed milestones in walking and speaking, achieving these at the ages of 3 and 4 years, respectively. However, by the age of 6, he was able to attend the primary school with the children of his age. The first seizure occurred at the age of 8, it was characterized by a sudden fall, gaze fixation, limbs hypotonia, and subsequent vomiting and drowsiness. The episode lasted for about 5 minutes. He was seen at the emergency department around 2 hours after, and the post-ictal neurological examination revealed no abnormality. So he had initial investigations, including MRI, laboratory tests, which revealed no significant abnormalities. However, a sleep EEG confirmed continuous spike and wave activity during sleep, and few weeks after, he started having a cognitive regression that was confirmed by a neuropsychological test. So here is his wake EEG. We can see a normal background, but we have here some biphasic spikes, mainly on temporoparietal regions. And here is his sleep EEG that shows an increase in activation of the abnormalities. His whole EEG Sorry?
Can you please put the presentation into presentation mode?
Isn't it in okay, I forgot, sorry.
Thank you.
So it was activated by sleep, and as you see, his whole EEG is like this. He has less abnormalities during REM sleep, but during non-REM, all his EEG looks like this. So first question, is it mandatory to have a whole night sleep recording to establish the diagnosis? I think the question has been addressed twice, but that will be an equation to review. Okay, 57%. We're right. So according to data, we can calculate the spike wave index during the first 100 seconds of non-REM sleep. So it's not necessary to have a whole night sleep EEG. So we tried various anti-epileptic medications, including valproates, levetiracetam, topiramate, ethosuximide, both individually and in combination. He had no seizures, however, no improvement of cognitive impairment, neither of the EEG. So at the 6 months, as he didn't improve, we tried the corticosteroids. We introduced them, as I said, at the 6 months. It resulted in temporary improvement of the EEG, but unfortunately, the cognitive impairments persisted, they didn't change. So after he was addressed for ketogenic diet, the patient was tried Atkins, but it was abandoned due to poor compliance. We then did a lot of medication adjustments with continuous. We keep on monitoring his EEGs. So since the abnormalities occur during sleep, would it be wise to administer anti-seizure medication only in the evening before bedtime, aiming to minimize side effects overall, particularly on cognition? Okay, half. So I think the answer is yes, and Professor Riviero will comment on this. So, following the challenges with the previous treatments, lamotrigine and clobazam were added to the regimen, but they did not lead to significant improvements in the patient's condition. After a year of treatment, lamotrigine was discontinued due to its lack of effectiveness, with the patient remaining on only levetiracetam and clobazam. So regular EEG monitoring showed a persistent SWAS pattern. One of these EEG showed some focal spikes during REM sleep. So he is one of the many EEGs we did that showed the persistent SWAS during sleep, as you can see. And here is a page from his REM sleep that shows some focal left temporal spikes. So in this patient, what other treatments could have been used, in your opinion? High doses of clobazam, amantadine, memantine, or all of the above? For this patient, we didn't exceed 10 milligrams. We just gave him 10 milligrams. So the right answer, the correct answer is all of the above. So at the age of 13, we started having signs of puberty and a significant improvement when Abdunnoor reached the puberty at 13, with the complete resolution of EEG abnormalities. And here's his EEG, as you can see, a page from his wake EEG, which is normal. Stage 2, beautiful cat complex and no abnormalities. And stage 3, as you see, no abnormalities. So we started tapering the treatment 2 months ago. And of course, we'll keep on the follow-up with neuropsychological assessments and continue the monitoring with the EEG. Of course, multidisciplinary approach is important here between neurologists, neuropsychologists, and other healthcare professionals. So, are there cases where patients do not fully improve after puberty? So most of you answered yes, and it's correct. Professor Riviero probably will comment about this. So my 2 last questions are kind of existential. Should we continue to consider these abnormalities as epileptic, given the fact that they are continuous but more periodic than rhythmic? And especially that they are reactive and disappear upon awakening the patient. And finally, in this patient that didn't respond to any of the treatment tried and who had only 1 seizure, was it justified to keep him during these years under anti-seizure medication? Thank you.
Yeah, thank you so much, Professor Amal. Again, very challenging. So I will please, Professor Riviero, for your comments.
Well, yes, again, the cases keep getting, they're all challenging, but hopefully they don't keep getting more and more challenging, or else I'll be talking for hours. But but again, a very interesting case. I mean, in this particular patient, your question is, should these be considered epileptic? And I think the answer is yes, because of the cognitive dysfunction or regression that you saw in the patient. So I think that the patient is having the cognitive dysfunction because of the degree of the epileptic abnormalities. I'm not sure that whether they're rhythmic or periodic makes that much difference. I think their abundance is better. But if we think about the ICU EEGs, where we talk about the ictal-interictal continuum, we know that even with the rhythmic and periodic discharges that people can have dysfunction. So I think, yes, we should still consider them to be epileptic. Now, your question about the, well, very interesting that the case stopped or that the EEG got better with puberty. That certainly has been reported. And in fact, in the past, we considered ESES to be a benign epilepsy because the EEGs got better over time. People weren't considering the neuropsychological aspects of that. But yes, we may see that epilepsies do get better with development, correct? I mean, we see this in people that have benign epilepsy syndromes. We see this in people that have, what in the past we would have called the malignant epilepsy syndrome. So I think with development, with the maturation of the nervous system, inhibitory systems become more active. But we can see ESES that persist into adulthood. So that can happen. We can't say absolutely that that patients will grow out of it over time, because they can be persistent. I think your questions about the clobazam and the treatments, yes, with the 30 milligrams, I would agree, going up on the dose. Amantadine has been used for ESES, and amantadine is separate from memantine. The amantadine has more to do with serotonergic systems, perhaps inhibiting seizures, as opposed to the memantine, which is more of an anti-excitotoxic agent. So I think both of those have a place in the use in the treatment of ESES. And whether people get better or not, in part, has to do with their underlying syndrome, right? I mean, if you've got one of the self-limited or benign epilepsies, we are going to expect that to regress, so to get better over time. We certainly know that with even what we called the benign Rolandic, or now selects, the spike wave index was related to whether people had cognitive dysfunction. So the greater the spikes, they can have cognitive dysfunction even in some of the benign epilepsies. So the underlying etiology or cause is also going to be important in whether the ESES persists.
Yeah, thank you so much.
Thank you, Professor Vielo.
Yeah, it's getting really more challenging. Our next speaker is Dr. Nibal Wael. So Dr. Nibal, Professor Nibal Wael from Baghdad, mic is yours.
Thank you, Ida, and thank you, Dr. Rivello, for accepting this case to be presented. Thank you, Gaz and Jessica, for all the preparations, and thanks to the speakers for those wonderful cases. Okay. So I'm going to present this case, who is a 6-year-old boy who presented, who was diagnosed with hemiplegic cerebral palsy due to an old ischemic insult. He developed at age of 5 months epileptic spasms, which responded to ACTH. This is the MRI, which showed encephalomalagic changes on the left hemisphere and in the territory of the left middle cerebral artery. At age of 3 years, he developed various seizure types, right focal tonic, focal evolving to bilateral, and myoclonic. Those were responded partially to anti-seizure drugs, sodium valproate, topiramate, levetiracetam, clobazam, and vigabatrin. At January 2023, the patient presented, few months before which the sodium valproate was tapered off. He presented to us because his seizures became more frequent and intense over time. They were focal clonic, bilateral evolving, plus minus bilateral evolving, with the dropping and absence. The EEG showed left frontal central vertex spike wave discharges with phase reversal. It was maintained throughout the record with multifocal epileptiform discharges on both hemispheres. So vigabatrin was stopped. Sodium valproate was re-administered. 2 weeks later, seizures disappeared, but the family noticed that he had excessive salivation with loss of speech and difficulty interacting with others. So a short EEG, 30 minutes awake sleep, was done. And you can see that it showed nearly continuous bilateral synchronous rhythmic slow spike, polyspikes activity, wave activity with a frontal predominance, without ictal events during the record or abnormal body movement. But he was irritable and during awake, and he had multiple movement artifacts. So this is the awake and the sleep EEG. So non-convulsive status epilepticus was diagnosed. He was hospitalized and treated with status epilepticus protocol, including infusion diazepam. After 5 days, he improved in regard of EEG epileptic discharges and in regard of his social interaction and speech and seizure. Not seizure, in regard of his cognitive or speech and social interaction. So he was discharged stable, slightly ataxic, verbally active and responsive. But you can see that there are a lot or abundant of multifocal right hemispheric vertex and left parasagittal sharp spike wave activity with repeated phase reversal throughout the record. So there are an abundant of focal epileptic activity. So he was discharged on anti-seizure drugs, oral, sodium valproate, clobazam, levetiracetam, and topiramate. After 2 months, he came with persistent focal epileptic activity, but 2 weeks later, he became aphasic, with increasing attacks of eye fluttering, social interaction, and that was worsened than in comparison to before, and he walked with assistance. The question is, what is primarily responsible for this clinical deterioration? So he was diagnosed with non-convulsive status epilepticus, discharged well, and then a new clinical deterioration has been occurred. So some of you thought that it is a recurrence of non-convulsive status epilepticus, and some of you thought of carbamazepine-induced disease, and some of you thought of both. So I agree that both of them should be considered, and for that, awake sleep EEG was performed. Again, it was short, 30 minutes duration. This is the awake EEG. Again, it showed interictal abundant multifocal right hemisphere vertex and left parasagittal spike wave discharges with repeated phase reversal throughout the record. But here is the sleep EEG. The sleep elements are difficult to be distinguished with activation of epileptiform discharges and long runs of synchronous slow spike wave complex with a frontal predominance with a spike wave index more than 85. So the diagnosis was SWAS. Now, what type of the following EEG can be used to diagnose disease? هي في الإعادة إفادة repetition is beneficial, but this is rephrased in another way. So again, some think that a shorter piece of EEG can be used, and some of you thought of all. Actually, the longer piece of EEG is used to in order not to misdiagnose disease, because sometimes if you cannot identify disease activity in the shorter 30-minute, let's say 30-minute sleep EEG, then you have to go into a longer duration or longer time EEG. So it is used for, in order not to, the overnight, the 24-hour EEG is used in order not to misdiagnose what is not identified in the shorter EEG if you strongly suspect disease. So overnight EEG is not mandatory to diagnose EEG. So the child was treated with a steroid in a form of methylprednisolone. Then he was discharged on oral prednisolone to be tapered over 6 months with an increasing dose of sodium valproate and clobazam. He became free of seizures and with infrequent repetitive clonic movement during sleep that were reported by the family. He had a dramatic improvement of speech, cognitive, and motor skills, and there was resolution of SWAS on subsequent monthly EEG. We were aggressive with the child in performing EEG. On October, and actually it was the 6th month of steroid tapering, seizure recurred twice a week. It was focal clonic, absence repetitive, with excessive mouth drooling. Again, EEG shows SWAS activity with an index more than 85%. So the third question is that, which management option is the best place for you to go next? So about half of the audience of the attendees will decide to go to monthly pulsed methylprednisolone, and some of you go with daily night benzodiazepine, and about 20% goes with resective surgery. Actually, in this child with such well-identified insult, structural lesion, we would recommend to go into surgery. Resective surgery is an effective treatment for selected cases, and I think this is the most appropriate selected one for surgery option. Producing long-term seizure freedom, resolution of disease, and stabilization of cognitive and behavioral functioning in most patients. In a very nice study of which analyzed about 500 of patients who have disease, it was found that the effectiveness of the options that were mentioned in the in the third questions, were as follows. It was 49% of patients showed improvement with anti-seizure drugs, 68% in patients who were treated with benzodiazepines, 81% in patients treated with steroids, and 90% in patients treated with surgery. Actually, what we did, the family refused, or it is actually not this family alone, but it is difficult in our region, in Iraq especially, to convince and persuade the family to go into surgery. I think they would agree. In addition, that we don't have an appropriate epilepsy surgery center to deal with this. This is our thought and the family thought, and they would prefer the long journey with the anti-seizure drugs or other medical options rather than going into surgical options. So he was treated with methylprednisolone, another pulse of methylprednisolone, and it wasn't beneficial. And then zonisamide and later ethozoxamide were added, but we were sure that they will be of no benefit at this stage where it becomes so resistant. And finally, we decided about daily oral diazepam at night, and it was difficult to give him or to try the rectal high-dose diazepam. It was difficult with that child specifically, so we decided to give the daily oral diazepam. Zonisamide was tapered off with the continuation of other anti-seizure drugs. And a month later, he came to us, and he was free of all types of seizures, and he had marked improvement of speech, social, and cognitive skills, EEG resolution of SWAS changes, and he had normal sleep elements, although they were asymmetrical. And we are planning to continue the daily oral diazepam for 2 years with monitoring, and we hope that the family or we can or that child can have a chance to get a surgical intervention. This is the EEG after daily diazepam. And thank you.
Yeah, thank you so much, Dr. Nibal, for again challenging case, which show that sometimes underlying etiology, structural brain abnormalities can lead to ESES. Professor Ravillo, for your comments.
Yes, again, thank you, Professor Nibal. That was a very interesting case. And I think what it really highlights is, as you showed the structural abnormality there, and I would agree with what you recommended, given that you had treated with a couple different courses of different agents, which worked short transiently, but then he got worse, we would recommend doing a hemispherectomy, which should be more curative. There's always been the thought with ESES that if the duration goes on for a certain period of time, and what we learned was 3 years, although I'm not sure there's any study or data that says 3 years, but the idea would be that if the ESES goes on for a persistent amount of time, that you're sort of damaging your circuits because of the persistent excitotoxicity. So the fact that you're able to treat the patient and then you get improvement, even if transiently, is telling you that there's still brain underneath there that can be repeated. So I totally understand the recommendation for the surgery, and I would agree with that. But as you mentioned, some of the logistical difficulties in performing the surgery. So I think what you did next was great, using the prolonged benzodiazepines. That certainly has been shown to be effective. The original benzodiazepine protocols from Denegri's group used it for a short period of time. When we started modifying that protocol, we were using it for a month, So we would treat patients, use it for a month, and if their EEGs looked better, we were tapering them off after 1 month of treatment, as opposed to Denegri, who had used it just in the hospital. What we showed was virtually 100% of the patients relapsed. So a short course of therapy is not enough. And so what you did is you kept the patient on the prolonged benzodiazepine therapy, and that would go along with how we modified the Denegri protocol to treat for 2 years seizure-free. And even in the setting of structural disease, you might be able to achieve ultimate seizure freedom. Now, the fact that he's got a structural problem might mean that he would relapse down the road, but I totally agree with the 2-year treatment. And one final point, initially they used rectal diazepam. We used rectal initially, but then we stopped and we went to oral. I don't think there's any really difference between using it orally or rectally. The oral gets absorbed very well. And of course, the rectal administration is more challenging or uncomfortable to the patients because they're awake. This isn't using it as a rescue med while they're in an episode of status epilepticus. It's using it in awake children. So we did ultimately change to oral.
Mm-hmm. Yeah, thank you so much, Professor Riviello. Our last case, but not least, Professor Dana Hasbini. So please, Professor Dana, the mic is yours. Is another very challenging case.
Yes, I would like to
see one of the questions about focal and so I am looking at the questions. Some of them are already addressed. تفضلي دكتورة.
Thank you. I would like to thank again the organizers, Dr. Riviello's presence, Dr. Raida, and everyone for this very nice meeting. I will start my case. Can you see my slides clearly?
Yes.
Okay. So my patient, she presented to me at around 3 years of age. She was she was a young girl with speech difficulty, autistic trait, and difficult behavior. And her history was negative. She had full-term pregnancy, normal vaginal delivery, normal motor development. However, she had limited speech. And she was already started on speech therapy, psychomotricity. The problem is that she was gaining new words, but losing others. And remember that she had autistic traits. So she was, again, in the history, she was well vaccinated, had surgery for adenoidectomy and tubes insertion, and vaccinated, and she had poor sleep. The physical exam was unremarkable. She had no dysmorphism, had circumference was normal, but she has very difficult behavior. She was very hyperactive, poor speech ability, though the eye contact was present, but it was very short. And this is presentation when she came first to me. Initially, she was started on risperidone by a psychiatrist. She became very aggressive. It was stopped. She was advised catapressant by another physician, but again, the parents were afraid to give her due to side effects. She was started on methylphenidate. Again, her behavior became worse. And so I started her on atomoxetine, which is Strattera. Her initial workup was non-revealing. The CGH, the karyotype, ABR were all normal. MRI brain was unremarkable. And preliminary metabolic workup was normal, but we advised whole exome sequencing. It was done and it was pending. So my first question to the audience, I will not answer the question. I would like to keep Dr. Riviello's comment. Would you classify this patient as autism or Landau-Kleffner? So I see like the response is around 50%. I will move to the next slide. And I think I'm not able to move my slides. Gus, are you still with me? Hello, can you hear me?
Yes, I can.
Yeah, I think I'm not able to move my slides for some reason. Could you please, could you assist?
Sure. If you could stop sharing your screen, I'll
I don't know what
share
happened,
it
but
for you.
yeah, I guess my screen is freezed, so maybe I can try again.
Dr. Adana, I had the same problem. Maybe you should click to go to the next slide. Click on the slide instead of clicking on the arrow on the laptop.
Yeah, maybe, and I try again. So, okay, all right. So I'll go to the next slide, and so far at this moment, would you do an EEG? Is there an indication to do an EEG on a patient who's already autistic, has bad behavior, gain some word, lose some word? So would you do an EEG on such a patient? So I see most of the people would like to do an EEG. And yes, an EEG was done, and the parents are frequent travelers. So they went to Turkey, and one of our colleagues did an EEG at that time. And I'm going to show you a couple of slides. This was a sleep EEG because we don't have an awake. The patient was very uncooperative during the awake state. And if you look at these slides, I show you a series of these slides. This is a double banana, as you can tell. And if you notice, we have frontal, mostly frontal discharges, right? Slow wave, bilateral, possibly more at times over the right side, more over the left side. And if you go on, this is her EEG all through. And if you look here, we have discharges ongoing. And so would you classify this patient as having ESES, yes or no? Because we have focal, frontal, at times more over the left, at times more over the right side. They're not diffuse, they're not all the time, but if you count them, yes, they are abundant discharges. So what would you classify this patient as, an ESES or not? And again, I will keep the comment for Dr. Riviello. Okay, so again, so some 57% of you decided not to classify it, where 43% decided to classify it. So we, in view of her bad behavior, in view of her listening, and in these findings, we elected to consider treatment for this patient. Now, what would you consider as a treatment? Would you go for clobazam, steroid, broad spectrum, anti-seizure medication, anti-seizure for focal, treatment for focal, or wouldn't you treat because the patient doesn't have seizure so far? Wow. So you see there's distribution of answers, and some of you elected not to treat because the patient didn't have seizure, but the majority went for broad spectrum anti-seizure medication. So in view of this, we elected to start the patient on clobazam. And we went slowly on clobazam doses. We start on first like 2.5 milligram. Then we increased gradually 5 milligram per day. Then we 5 in the morning, 10 in the evening, and then we went up to 20 milligram. Unfortunately, the patient behavior deteriorated, and the EEG was the same. There was only a very subtle improvement, but then there was no marked change, neither in the behavior nor in the EEG findings. So we went to the steroids, and we started the patient on 2 milligram per kilogram per day steroids for 2 months, in addition to the clobazam, and she was already on atomoxetine. And after 2 months, this is a sample of her EEG. I don't have now all her slides, but they're quite all similar to these findings. What we were left with, only a couple of frontal some discharges here, sometimes on the left, rarely on the right side, but just some focal frontal discharges. So we really had like more than 60% improvement on her EEG findings. And then the parent again traveled. So after they went to another country in Europe, and they were seen by one of our colleagues who, after these findings, elected to stop gradually clobazam and stopped steroids. And one of the main reasons why these stopped, not only because the EEG improved, but because the patient behavior continued to be very bad on benzodiazepines, and she became obese, and she had, sleep disorders, sleep worsening. Now, again, the parents came back to me after 1 year. Can you hear me well, please? It seems my connection is unstable. Can you hear me well?
Yes.
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 Okay, so she came back to me after 1 year, and the parents continued of complaining that her speech, wherever she gained, though it was limited, worsened. And her EEG at that time showed only very rare multifocal spikes, some slowing in the background, but we didn't have the discharges that we found at the beginning. And at that time, I elected to put her on lamotrigine. I thought that maybe this patient, since she didn't have seizures, but she only have focal discharges, maybe lamotrigine would help to her cognitive abilities. And you know that we can go up very slowly with lamotrigine, so maybe it will help her. And the whole exome sequencing, interesting, which showed she was a carrier for Galloway-Mowat syndrome. So just for the audience, short brief, what is Galloway-Mowat syndrome? It seems a very rare syndrome, but it is associated with malformation of the brain, seizure, hypotonia, and apparently patient have a problem in acquiring speech, and they have acquiring any purposeful hand use or verbal communication, and it is associated with severe and profound intellectual disability. It's also associated with kidney disease, and most patients do not survive after teenage years. And it is inherited in an autosomal recessive manner, and most of them have abnormalities in the WDR73 gene. Now, the patient didn't have so far any kidney problem, but she was instructed to follow well with a nephrologist. Now, after the parent, again, now that they traveled to Dubai. So as I told you, they were frequent travelers. So the patient then developed in November 23, first episode of prolonged seizure. She had staring, confusion, and then fear, and prolonged staring and hypoactivity associated with tachycardia, but then followed by generalized tonic-clonic seizures. She was in a status epilepticus. She was admitted in Dubai and started on levetiracetam in addition to lamotrigine. And they did the EEG that showed prominent bioccipital slowing, multifocal spikes, mostly bioccipital, mostly on the left, only few on the right side. After this, Lamictal was stopped because Lamictal she was on low and increasing doses of Lamictal, but in view of status epilepticus, Keppra is better in this case. So she came to me only recently, last week. Her EEG showed slowing. We didn't have any more the spikes nor the sharp discharges. We had some background slowing in addition to frequent left mid posterior temporal delta slowing and right posterior temporal slowing to a lesser extent. So we didn't have any more the findings that were present at the beginning. The child still doesn't have speech. The behavior is somehow controlled. The parents they take her to frequently to do speech therapy, psychomotricity. She has a special shadow person that helps her all the time. I elected to present this case because it is really a challenge. Whether should we treat this patient as Landau-Kleffner or whether all these symptoms are explained only by autism. My second challenge was, is there really an indication to do an EEG in these patients, even if we don't have seizure? Should we do an EEG on patient? Because from the beginning, she didn't acquire speech in order to say her speech was, worsened. And my third question were these findings. Should we classify the EEG finding as ESES? And should we treat EEGs? I mean, the question, or treating EEGs in normal patient, if you have somebody coming for whatever reason, you do an EEG, you have some findings, would you really treat an EEG? And then my fourth challenge is that treatment, the patient, what would you do in these cases? It was good that she improved on a combination of clobazam and steroids, but for how long? Because in this case, the patient were traveler, they were seen by many physicians. So I will leave the ground for Dr. Riviello, and thank you again for listening.
Yeah, thank you very much, Professor Dana. It's actually all of the questions that you are asking are in the question answer panel. So please, Professor Riviello, for your comments.
All right, thank you. And Professor Dana, thank you very much for that interesting case, which of course,
thank you all.
There's a lot that we could say about it. But one question, I think you said initially that the patient did have some poor speech, but that sometimes the words were coming and going, so that there was some mild language regression.
Yes. She was on speech therapy, and each time she would gain a couple of words, she would lose them. But she had also the autistic trait.
Right. So, it's very interesting because if you look at the original definition of the syndrome Landau-Kleffner by Landau and Kleffner, who Dr. Kleffner was actually a speech pathologist at the St. Louis School for the Deaf, because these kids didn't have seizures, but they had aphasias. So they said that patients had to be normal in order to have Landau-Kleffner syndrome. So that was one of the requirements to say somebody had LKS, that they had to have normal development. Now, that may not be entirely needed for LKS. Many series of patients with LKS have had mild neurological abnormalities and have had language regression. The interesting point is that if you look at kids with autism or pervasive developmental disorder in the past, a very good percentage of those patients have language regression as well. So it can be very hard to say whether somebody has LKS versus PDD or autism with regression. I guess personally, I would probably call this kid autism with regression because of the degree of the autism. And in that there's some parts of me that don't think it matters. The fact that you have somebody that has regression, no matter what their underlying development, if they lose language, some people would have called that a Landau-Kleffner variant, with the variant being that they weren't totally normal to begin with. So I would have gotten an EEG on that patient because of the regression in the language, that even though the language was abnormal to begin with, there was some degree of regression. There's also been the term of what's been called congenital Landau-Kleffner syndrome, and that would be somebody who has major language delay, but when you did an EEG on them, they had a very active sleep EEG. So that was referred to also in the past as congenital Landau-Kleffner. But so the fact that they had autism to begin with, they had some speech delay, they had language regression. Of course, like I said, I would totally agree with doing an EEG. And I think as a general rule of thumb, any child that has underlying cognitive dysfunction or motor dysfunction, any kind of neurological dysfunction who has any type of regression, even in the absence of seizures, should get an EEG, because we know that those patients may be more prone to have an epileptic regression. And you're looking at the EEG with spikes as a biomarker for potential treatment. Your third question is very, very interesting about would you classify ESES? And it's actually a paper that we had written from Boston Children's, where we looked at people with focal ESES on an EEG versus generalized ESES on an EEG. And the clinical manifestations are basically the same. So whether you have something that's generalized or whether you have something that's focal, the symptoms can be the same. Your question about where the spikes are located. When we do a spike wave index, for some of the listeners, a spike wave index means the number of bins with spikes versus the total number of bins, and we're usually doing it in sleep. We don't count spikes in different locations. If a spike is frontal, if it's occipital, we count it as a bin with a spike in it. So I would call that have ESES even with the multiple spikes. But also the location of the spikes within the ESES can predict what's the clinical dysfunction that you get with that ESES. And so, for example, if you look at the patients called Landau-Kleffner syndrome, the majority of them are going to have, particularly in the waking state, maybe, you'll see their spikes, or one of the EEGs that we showed today had a run of temporal spikes, even within the bursts of the ESES. So if we see something that's posterior temporal parietal, I'm going to think that clinically their syndrome might fit more into a language regression with ESES coming from the temporal lobes. If we see something more frontal, patients with frontal ESES have had either more of a cognitive or behavioral regression, and sometimes people with frontal spikes will have a motor apraxia. So basically, where the spikes are located within the ESES may help you predict the person's syndrome. We've seen patients that came in with posterior spikes, posterior ESES, who lost vision. And when we treated the ESES with benzodiazepines, their vision got better. I've seen patients that have parietal spikes who have had the prosopagnosia, and they've not been able to recognize face. So where the spikes are concentrated in the ESES may also help you with to predict where their dysfunction is going to be. And as far as treatments, I would treat focal ESES the same way that I would treat generalized ESES. I don't think it matters. Now, I have seen in the patients with autism who had ESES that you sometimes can get benefits. You may clear up their spikes, but depending on what their underlying etiology is, or their spikes may come back to where ultimately you treat them and you don't get any further improvements in their dysfunction. But I think I would always try, if I see ESES, particularly in somebody with any kind of clinical manifestations, and especially if there's been regression, I would treat them focally the same way I would treat them in a generalized manner.
Yeah, thank you so much. Really, really very useful and very helpful.
Thank you so much, Dr. Rabil. Thank you for answering all these questions.
يعطيك العافية. Really, I would like to thank all of our distinguished speakers, Professor Riviello, for valuable input. I'm looking at all of the questions that I have. I think most of it was already addressed during the discussion. Professor Riviello, maybe I have like only few questions in the panel of question and answer. Maybe I will ask your opinion. One of the questions.
Yes, no, certainly. I have all the time you need.
Yeah. One of the question, would you also consider sulfiam in treating ESES?
Yes, I mean, sulthiam is one of the spike suppressors. It has been used in some countries as treatment for the now selects because of its spike suppressing abilities. So yes, I've used it. I mean, I've not been impressed with it in the severe cases, but it may be that I used it late. And in part late because it's not available in the United States and we have to get it through special arrangements. So I never used it as a first-line medication the way people may have been able to use it in other countries. The problem with it is it actually does cause more breathing problems. It can cause some apneas and sedation, and it is also a carbonic anhydrase inhibitor. And so you have to be concerned about kidney stones. And in this patient with the Mowat syndrome or with the Galloway-Mowat syndrome with a kidney disease, I would have been a little reluctant to use the sulthiam in that patient or any of the other carbonic anhydrase inhibitors because of the risk of kidney stones and having renal dysfunction secondary to the stones.
Thank you so much. There is a question which was repeated about dose of steroid used in, it was already addressed, but would you, because I saw this question multiple times
Right.
in patient who had ESES.
Well, I don't think there's a single answer to that. I mean, there's different protocols that different people have used. The protocol that I used was the one that Jerry Stephanatos, who was a neuropsychologist, came up with, and I forget who Jerry got it from, but we used 2 milligrams per kilogram of prednisone or prednisolone for daily every night for a month. Then we began to taper. We went to 1 milligram per kilogram for a month. Then we went to 1 milligram per kilogram every other day for a month. And then we dropped it to 0.75 milligrams for a month. And then we went to everyday dosing with a treatment protocol of over 6 months. And the reason we used that was because of the fear of if you didn't treat for long enough that patients would develop ESES again or have recurrence. But people, if you treat patients with steroids for a shorter course of time, and perhaps they're also on combined medications such as valproate or clobazam, it may be that you could break the cycle of the ESES with the steroids and then be able to taper them off of the steroids when they're on some other medication. I don't think you can predict in a given patient what their response is going to be. And particularly if somebody gets the adverse effects of the weight gain and the hypertension and the various things that go along with chronic steroid use, even if they have a recurrence, you're going to be reluctant to go back and use it on a daily basis. But again, that's where I might use the pulse steroids. You know, you could use the monthly pulse steroid treatment. People have done dexamethasone monthly IV. People have used every other day pulse steroid treatment orally. I don't think there's a single protocol that there's not absolutely one single protocol. I think whatever you use that works may be beneficial, but I have seen a number of kids with ESES who were treated with only short periods who then regressed. And of course, then we went back and used the longer 6-month protocol.
Thank you so much. There is another question. If there is any place for ethosuximide in ESES, especially in substrate negative cases in your experience?
Yes, very good question about using ethosuximide. In one of the, ESES became very, well, I don't mean to say popular, but it became more recognized in the late 80s, early 90s. And there was a conference on ESES in Marseille, I believe, in the early 90s. And there was actually a book that came out of that conference, which I don't think it's still available, but it's not in print, but it may be available from some of the used bookstores. But they did a survey there of the participants, and of the three medications that people were on the most when ESES resolved were a benzodiazepine, valproic acid, and ethosuximide. And I have seen people with ESES who have particularly brief staring spell seizures, even if they have focal ESES with staring spell seizures, where ethosuximide did help them. So yes, I have used ethosuximide in ESES, but I think one of the key things for the treatment is using something early, because for the most part, in the book that I referenced, these were all medications that had been started very late. So it might be that using ethosuximide early on, particularly for somebody that had a lot of absence seizures, the ethosuximide could be very helpful. I have a patient who had an early stroke, who had unilateral ESES, but did have frequent staring spells, and ethosuximide was what ultimately brought them under control, despite the fact that they had a large MCA infarct. So some people say it's really the seizure type that you might treat with the anticonvulsant, as opposed to absolutely saying that it's focal or generalized on the EEG.
Yeah, thank you so much. There is another question. Can we classify patient as having developmental epileptic encephalopathy, slow wave activated sleep, based on the latest ILE classification, as he or she has speech delay from the onset, from the start?
Well, again, that was what I sort of said people might have in the past called congenital Landau-Kleffner syndrome, with the idea would be in the pure Landau-Kleffner syndrome patient that they've got normal language development. They then develop some type of focal insult, usually in the posterior temporal parietal region, and then they regress. The idea of the congenital Landau-Kleffner would be that they've got abnormalities to begin with that generate spikes on the EEG, and then they regress later in their language because the spikes have picked up more in the area that was originally abnormal. So I would say yes to that.
Yeah, thank you so much. I think the last question, all of these cases, Professor Riviello, provoked a lot of questions. As I mentioned, it's addressed while you were discussing each case separately. The last question that I found also, it come repeatedly about dose of Valium, diazepam.
Yeah, so the dose of Valium, and again, a very good question, or a very interesting question. And the reason that I say it's very interesting is because I had come across the Denegri paper about, well, now if I say it's 2024, I came across the Denegri paper about 25 years ago, because I think it came out in the late 90s. Now, to be honest, I actually didn't see the paper first. One of my patients' mothers, who read the internet incessantly, came up with the paper, and she asked me once if I had ever heard of the use of the high dose Valium for ESES. And of course, I told her, yes, I had. Of course, I hadn't, but I went and looked it up. And then we modified that protocol by Denegri. And Denegri used 1 milligram per kilogram. So when we modified the protocol, and he treated for just the inpatient time. So they brought the patient into the hospital. I believe they gave them a single dose of high dose rectal diazepam. And that's why we used rectal initially. And then they sent them home, and then didn't treat them again. Those patients, if I remember right from the paper, they all relapsed. So when we modified the protocol, we brought them into the hospital. We treated them 1 night or 2 nights to get a decrease in their spike wave index. And then we sent them home on, we used 1 milligram per kilogram with a maximum of 40 milligrams. We got that maximum of 40 milligrams through an interaction with our pharmacy specialists. And we decided that a maximum of 40 milligrams would be relatively safe. But then we sent them home on 0.5 milligrams per night with a maximum of 20 milligrams for a month. And that was our modification of the protocol. I know other people, though, have used 0.5 milligrams as their initial dose in the hospital. So I'm not sure, again, that there is one dose that's going to work. You could argue that and I've always given the high dose Valium in the hospital because of the risks of the sedation, the respiratory depression. But to be honest, we almost never saw any adverse effects initially. People might get sleepy the first night, but a lot of them did not. And then we sent them home on the 0.5 for a month. As I said earlier, they all relapsed when we took them off. And that was when we switched to treating for 2 years seizure-free, the same way back then you would have done for somebody with epilepsy. So I'm not sure that if you used 0.5 initially and it worked, well, then it worked. So I don't think there's a set dose. The 1 milligram was just what we had used. The high dose clobazam that they did at Boston Children's, I think Vega was the first author on that, and Toby Lodenkemper and Sanjeev Katari were some of the other people on that paper. They brought the patients in with clobazam and gave them 30 milligrams, again, as a maximum. But I've not been using that for the initial dosing. I've been giving the clobazam orally, like some of our other cases that we heard today, of starting people on 5 or 10 milligrams nightly, depending on their size and weight, and then working up to 30 milligrams over the course of about 5 or 6 weeks, and then repeating their EEG. If you did 20 milligrams versus 30 milligrams, I'm not sure that we can say that there was that one of those is any different. If you get a response, well, then it was the right dose.
Yeah, thank you so much. I think this is the last question. As I mentioned, I went over all of the question posted, and it was discussed during commenting on each case. I think it is time to conclude and really to thank all of the organizers, Professor Riviello, for really valuable time during this webinar, our distinguished speakers, Professor Iman Maher, Dr. Riham, Professor Fatma Kamoun, Dr. Muna Ali, Professor Amal Sati, Professor Nibal Wael, and Professor Dana Haspini. Really, thank you very much for all. And there is a comprehensive survey, a complete survey to get your certificate for all of the audience. We hope that you enjoyed this webinar, and hope to see you in near future with other webinars. Thank you so much.
No, and thank you very much for the very interesting cases and for the time everybody spent putting those cases together.
Yeah, thank you.
Thank you all. Thank you, Dr. Viello. Thank you, Raida. Thank you all for this very interesting and fruitful meeting.
Thank you, and bye-bye.
Bye.
Thank you.
Great to see all you.
Thank
Bye.
you.
Thank you. Bye-bye.
Thank you very much.